Actually, I do not have slides, so I won't be sharing my slides. So whichever slide you want to keep on, you please go ahead. Am I audible to all of you?
Yeah, yeah.
We need any adjustments in anything? No, we are okay?
Yeah.
Great. So I can see that there are 48 participants, and it's very nice to see all of you. I think in the present time, when the human contact has become so less, I really appreciate seeing everyone. And that's something that I've learned during this COVID time. So, good morning again. What Alok has told me to do is to give you a little overview of the GNE myopathy, particularly with respect to our country. And I'll take you through how things have developed in the last many years, and that will prepare you a little bit to the advances that experts will be telling you about. So when I was thinking about it in the morning, I remembered the Asian and Oceanian myology meeting that we held in 2009. I'm not completely sure whether it's 2008 or 9. At that time, there were a few patients in India who had a distal myopathy, and the pathology showed rim vacuoles. So these patients were being kept aside. And for that meeting, Dr. Nonaka was to come. Dr. Nonaka, as you know, had worked in Japan on what was then called the Nonaka's myopathy, the distal myopathy with rim vacuoles. And Professor Argao had talked about myopathy, where he sort of focused on the quadriceps muscles being spared, where everything else got affected. So Professor Nonaka had come to Mumbai, and from the Bangalore group, I think Gayatri and Nalini, and I forget who else was with them, someone else, they showed their cases. We had a few cases in Bombay, which also we shared. And Dr. Nonaka felt that, yes, they look quite similar to what we have in Japan as distal myopathy with rim vacuoles. So I think that was around the time when the background was set that, okay, these myopathies seem to be present in India. Till that time, we didn't know. Actually, I have recently taken a review of the work done in muscle disease in India. And it goes back to 1950, where people started working, Sarla Das and a lot of them. But there was this clinical amorphous sort of material under the myopathy subsection. This was the first time in 2008 or 9 that Nonaka said, and we felt that, okay, this exists. And then various groups have started working on it. So what is this myopathy? This is a autosomal recessive genetic condition. Now, what's the autosomal recessive condition? That means that one bad gene has come from, or faulty gene has come from the father, one faulty gene has come from the mother, and therefore both of them may not suffer the illness, but when both the genes come to the patient suffers. Why I am telling this? Because a lot of patients ask me, you are saying that this is a genetic disease, but my mother doesn't have it, my father doesn't have it, my sib doesn't have it. Why are you saying that this is a genetic disease? So that's how the inheritance is, what is called a recessive inheritance. That people who have one copy of the variant, the bad variant, they don't suffer, but they pass it on. And when both parents pass on, then something like the disease manifestation comes. So that's something that I think everyone should know. The second point is, I don't know how much applicable that is in this condition, but sometimes the bad genes arise by themselves. They are not present in their parents, but they arise by themselves. These are called de novo or new mutations. So you could theoretically have in genetics a condition where one person suffers a genetic disease and no one else in the family suffers. So if in your family there's no one else, don't think that it can't be a genetic disease. It can be a genetic disease. These kids are very well when they're born. They are okay when they are toddlers and young school-going children, early college years, and that's when the thing starts coming, it usually comes with a food drop. That they start tripping easily, they start falling, and then slowly and steadily the food drop sort of takes over, and then they start going to the doctors. Now, food drop has a big differential diagnosis. So the time taken for your doctor to reach the diagnosis can often be long, because food drop as a manifestation of a muscle disease, everybody doesn't know. Let's also face the fact that in our huge country, with this huge population, our healthcare services are skeletal. Expertise in every field is not easy to come by. And therefore, patients have taken years to reach a doctor who understands their disease when it comes to GNE myopathy. And the average time period for the diagnosis is still quite a bit, though hearteningly it is reducing. And that's thanks to the internet, that's thanks to the communication ability that patients also can read. They can ask their doctor what is happening. Doctors also can read as and when they want. They don't need to contact an expert every time, or they can contact an expert easily. So over the last few years, particularly last 5 years, I find that the time taken for the diagnosis is slowly shrinking, and people are coming to the right places more quickly. The other thing that this disease does is it also affects the small muscles of the hand in a lot of them, which is a feature that has not been so much outlined, but that can sometimes be a problem in daily activity. There's another Indian peculiarity. The Indian peculiarity is that in our lifestyle, a lot of us sit on the floor, and the way we are, the way we use the toilet facilities, there's a lot of squatting involved, or sitting on the floor and getting up from the ground involved, particularly in the rural settings in India. And that also becomes very difficult very quickly. So there are people whom I have seen who come and say, "Doctor, I can't get up from the ground." They don't come with food drop. When you examine them, they have a food drop, and they also have weak muscles in the pelvic girdle. So that's the second presentation, which is a little common in India, and it's not that much mentioned in the literature. That's because the way the custom is. So let's go back a little to how this myopathy has evolved. You know, Professor Nonaka in Japan had patients, and he called them distal myopathy with rim vacuoles, or Nonaka's myopathy. That's because one of his colleagues, Miyoshi, had described another myopathy where the back muscles of the leg are affected. Here, the front muscles of the leg are affected. So this was different than Miyoshi myopathy, so he called it Nonaka's myopathy. And Argao called it quadriceps sparing myopathy. Both of them were working on the genes. And as luck would have it, both the groups, almost at the same time, found the same gene. And they realized that they were working on the same disease. So the Israeli Jews that Dr. Argao was working on, and the Japanese patients and the Korean patients that Dr. Nonaka was working on, it was actually the same disease. So then a consortium was put in place, and people who have been working came together, and they said, look, people are getting confused with all these nomenclature. There is a nomenclature of Nonaka's myopathy, there is Argao's myopathy, there is distal myopathy, rim vacuoles, there is hereditary IBM, hereditary inclusion body myopathy. So let's drop all these names. And now that we have found the gene, let's name it after the gene that produces it. So that's when it all became the GNE myopathy. So now we call it a GNE myopathy, but this is the background. And this has happened in more than one muscle disease. The different groups in the world are working on different clinical features, diseases with different clinical features, and they finally realize that it's the same disease. This is the second example is the Miyoshi's myopathy. One group was working on limb girdle dystrophy, and Miyoshi worked on gastroc myopathy. And more or less similar time, they came to realize that it's the same disease. So, GNE myopathy. Where all in India is it reported from? If you ask me, I think it is everywhere. It is everywhere, all over the country. But the centers that investigate such conditions in India are few. So there is a lot of information from NIMHANS, Nalini's group, and some genetic information also they gave quite early on about this disease. There is information from our group in Western India. There are manuscripts from Northern India, from PGI Chandigarh, where they prefer to call it HIBM. But when I read them, it looks the same to me. At the time of the presentation, they don't have the genetic data, but I think it's the same condition. From East, in general, information about every disease in India is less, for whatever are the reasons. So I think it's everywhere. You can get a patient from anywhere. But more often than not, you will encounter these patients in communities that practice consanguinity, where you've got these marriages, cousin marriages, marriages in close relatives. That's where the autosomal recessive diseases become more manifest. And I think South India is one such place where community marriages are, where marriages and relatives are very common. Working in our setup in Bombay, which is one of the most cosmopolitan population that I see, still I think community marriages are very prevalent in India. Very, very prevalent. Whichever community you're born in, by convention, you're likely to marry in that community. I think much, much more than choosing your own partner. So community, there's some sound. Am I coming close to my endpoint? Just 5 minutes, yeah.
Please mute.
Somebody's mic needs to be muted. Yeah. Okay. So community marriage as a concept is not much different than cousin marriage or marriage within direct blood relatives, because that community is carrying certain genes more than the others. So I think that's something that everyone who's listening to this should realize and understand, that our ages of this behavior, marrying within the community, for whatever reason, social ease, whatever, has resulted in genetic pooling within our extremely diverse genetic data in the country. And that's a subject by itself. But when I was studying some of these the GNE cases in Western India, I had some patients who came from Rajasthan and Saurashtra. And we realized that these patients have a separate genetics as compared to the genetics that generally exists in GNE myopathy in India. Generally, GNE myopathy in India, you have the WAL 727 as at least one of the variants. Now, what's WAL 727 doing? How bad is that gene? And all that, I think in course of the day will be elucidated to you. But these Rajasthani people have a different gene, and that they share with the Roma, the gypsies of Europe. So I think that's another interesting migrational history that we got from this, that the Roma originated in Rajasthan and then went to other places in the world. So I think at this point in time, if I was to give you an overview of the condition, I think from a time when we were wondering whether this myopathy exists in India at all, we have come a long way. We know that it exists. We have a reasonable idea of the genotype of these people. We know how this presents, we know how this sort of moves, where all is it known. Though my guess is that for one diagnosed case, there must be at least 10 or more undiagnosed cases, because they don't come to attention. Everybody can't come to medical attention. We're not that advanced in terms of availability of medical expertise. And that is where I think in the last minute, I would like to say that efforts like what we are doing today are absolutely invaluable. See, most of the doctors and most of the groups are studying many diseases. So their focus is multi-pronged, their money is divided, their efforts are divided. But here is one organization by Alok, Sudha, and everyone else, which focuses on one disease. So you are sort of going to look at only this disease. You've got researchers, and so many of them were described in the morning before this talk started. I'm quite sure that with this sort of a focused approach, we will reach somewhere. There is no need to believe that we in India always have to lag and follow what happens everywhere else. I'm quite sure that such a focused effort, very few such focused efforts must be existent on this disease anywhere in the world. So let me congratulate everyone who's doing this, particularly Alok and Sudha and their daughter, Shilpi, who's done so much. I mean, she's an ambassador for this disease. So with this, I think it's 9:29, so let me finish my talk. I wish this conference a success, and I hope that together, someday, not very far from now, we will know more about what to do with these people and how to improve their quality of life. Thank you very much again. Thanks for asking me to be here. I absolutely will enjoy the rest of the day, and so will you. Thank you.
Thank you so much, Dr. Khadilkar. We just request you to wait a little bit because the questions will be after the next talk. So I'm sure patients would have some questions. So all the participants could type their questions in the chat box, or during the discussion time, you can raise your hand and then ask your question. So now we can move on to the next talk, which will be played by video. So this is this is Lale Welsh talk. Lale is not able to, because they have some internet issues, she has sent her recording, so we will be playing it.
Hello, everyone from Los Angeles. Good morning to everyone in New Delhi gathered there. I'm sorry I can't be with you in person, but I guess that's true for us all. For those of you who haven't, I haven't had the pleasure of meeting. My name is Lale Welsh. I am the CEO of the Neuromuscular Disease Foundation, and I'm very grateful to Dr. Bhattacharya for inviting me to speak at this conference to all of you. I know that this is...
Hope everyone can hear.
Yeah.
This is a very strange time for us during COVID, and when I was speaking with Dr. Bhattacharya a week or so ago, he told me things were really bad in India, and I remember thinking, well, you know, maybe it is bad. I know that COVID-19 has been very, very disruptive. We've had millions of deaths, and I understand that the death rate, though it's hovering somewhere under 1%, it's so widespread that so many people have been prematurely killed by this nasty virus. And obviously there's a lot of things that we can't do that we wish we could do, this conference being one of them. But I think that there's another way to look at it, which is the old school is giving way to novel concepts and new technologies that is a simple part of our evolution. If you think about it, back in the day of the horse and carriage, I'm sure they were lamenting the coming of the locomotive. I remember my Scottish grandfather telling me that his mother during that time had spoken with her doctor, who assured her that traveling at 40 miles an hour on a train would be terrible for the human heart, that the human heart would not be able to withstand that kind of speed. So as far back as our history can go, there's been people worried about change and worried about the kind of evolutionary things that seem so disruptive at first, but really have a silver lining. In the case of COVID-19, I realized entire industries, universities, the way we go to school, things like insurance, banking, hospitality, travel, all of these things have been really disrupted in a terrible way. But on the flip side, there's a bunch of small things that are happening and new shifts to new technologies that are making things more popular here in the United States, for example, while the restaurant business in terms of eating in has subsided and a lot of restaurants are permanently out of business. The food delivery business is flourishing. People have to continue to eat, and novel ways of getting that food to people is actually a new opportunity. In the same way, we are experiencing that kind of disruption in the intersection of biology and technology, where the old school ways of doing things might be disrupted in favor of new ways. The future is literally here. One of my favorite futurists, a man by the name of Alvin Toffler, who passed away, unfortunately, 3 or 4 years ago, my favorite saying of his was that the illiterate of the 21st century are not people who cannot read and write, but in fact are people who cannot learn, unlearn, and then learn something new again. And that is actually where we are. We have to learn to think about things the way we used to in a different light. With the comment that that's how things are done is no longer going to work. In terms of how that affects us, we can think about academia, the way peer-reviewed papers, the way scientists can't share information until it's published. These things are all going to have actual impact on everyone, good and bad. But ultimately, I believe for the patient, it'll be a good thing. For example, in 5 years, Elon Musk assures us that driverless cars will be here. Heck, he's building colonies on Mars. Today in Los Angeles, we heard that a CRISPR baby calf was born, actually in Australia, I think. The most important thing in all of this change is to really understand, as long as we understand the general outline of where we're headed as a community, and we're sure about that, and we're together in that, I believe it's going to be okay. And in this rare disease community, I really think we are going to make some tremendous strides. So I'm very, very hopeful. At NDF, I want to give you some specific examples about how we've coped with COVID-19. Right around sometime towards the end of February, it became very obvious to us that all of the conferences that we had planned on attending were getting canceled, and this was going to have a tremendous effect on our ability this year to be able to make our relationship happen with a biotech that was then going to take all of the research we're doing and take it to market and help us with our gene therapy. So we accepted what we couldn't change, and we started to think about in ways in which we would be able to adapt, because we believe that if you don't adapt, you're going to get left behind. So we learned how to deal with what I call the SOS, the setbacks, obstacles, and surprises, by having a clear vision of what we want, not just for our patients, but also for our scientists. So sometimes those things jive and sometimes they don't. We made what we call a triangle, ensuring that we talked about programs and strategy and scientific decisions that affect the stakeholders by gaining perspective and really validating what we hold to be true, which is at the end of the day, we work for the patient, we are here for the patient, and what serves the patient serves us. With that in mind and no other shibboleths, we really were able to reimagine a new way of doing things. We reimagined what patients and families might need during a very scary time. During a time of uncertain future, we really understood that once we realized that COVID wasn't going to affect our patient population any more badly than the rest of the general population, we could exhale. So we started to think about what could we do that could actually enhance the lives of our patients. And one of the things was to re-educate doctors about what it is to see GNEM patient. We have a recording that was made today of a patient, former board member of ours, who herself is a physician, who went through surgery for gastrointestinal issues, but her surgeon couldn't believe that she couldn't walk and thought that it was related. And it drives home the point that really having GNEM-specific doctors in multidisciplinary ways is an important issue. Also, another thing that came to mind was these telehealth clinics. I myself had to see a doctor through telehealth, and I found that I actually kind of liked it. It's much better than sitting in a cold waiting room. So some of these things that we had to reimagine had benefits, and some of them were more difficult. We also were able to step up our biotech discussions in spite of the fact that all of biotech right now is pivoting towards creating a vaccine for COVID-19. We were able to expedite our conversations in virtual ways by attending virtual conferences that actually saved us a ton of money and have continued to keep us in their periphery. And of course, the benefit that we see the most of right now is that it actually saved us a ton of money on travel, on hosting events, and on a ton of other things that have become better, faster, and cheaper. Specific examples include changes in our program, such as outreach. We basically took our entire symposia, which is considered very, very popular now. Patients attended. It's a big to-do every year. We fly patients in, we fly scientists in, we have people getting a ton of information, all jammed in as tight a space as possible in the course of 1 or 2 days, because to extend it to 5 or 10 days would be cost prohibitive. So the result has been, while we miss seeing everyone, that we've actually expanded the reach by a factor of at least 4 right now, and it's growing all the time, because we've not only been able to break the speaker series into bite-sized pieces where every Friday one recording is made. People are able to download it, the recording, and watch it on their own time, but also maybe absorb the information in a way that's more meaningful. And also, we've been able to have that be viewed by people who would normally never have been able to attend our conferences. So there is another silver lining that we think has happened as a result of COVID-19, and it's something we wouldn't have thought to do otherwise. So I think it's very, very important. In addition, because we did start the speaker series with a bunch of scientific presentations and are now pivoting towards more patient-centric topics, our scientific understanding has grown and the reach has broadened, and we've got new scientists and new physicians contacting us and learning about this. So it's actually been a tremendous success, and something, again, that we owe to COVID. One of the things that I'm most proud of is that not only we didn't prevent ourselves from working during COVID and give up, but we actually expanded our programs to include one thing that is tremendously popular, which is a multidisciplinary GNEM-specific clinic designed for patients of GNE myopathy who may have a common cold, who may have heart disease, who may have any number of ailments that happen to everyone, but to be able to be sure that they're seeing a physician that is trained in GNE myopathy. These sessions are paid for by NDF. We're currently in beta with the University of California, and we'll be launching those very, very soon. Because of HIPAA regulations that have been loosened somewhat during COVID, we are able to see patients across state lines in the United States, and we're looking into whether or not we're able to consult with patients in international countries and other countries. If not, what we realize, if this is as well received as it seems to be, that we will want to work with organizations such as this to be able to bring that kind of programming to other countries, where patients are able to have a telehealth session with a number of different kinds of doctors, neurologists, geneticists, nurse practitioners, nutritionists, physical and occupational therapists, genetic counselors, and of course, one of the most popular of all of the sessions is with our own Dr. Carol Gelbard, who is a trained psychiatrist who meets with patients and does a need assessment depending on where in their cycle they are. As you guys understand that a patient who is newly diagnosed has a different set of emotional needs and concerns and questions than someone who is further advanced in the GNE myopathy, but maybe is getting ready to transition from a walk from using a cane to going into a wheelchair. At the end of the day, the emotional wellness and well-being of the patient is incredibly important and part of our approach to treating the whole patient. So right now we're in beta, and we are able to serve with this particular program that is in beta. We are going to be having 6 sessions per year, all, as I say, paid for by NDF regardless of health insurance. So any patient who feels that they need that can in fact take advantage of it. And if you need more information, there is a topic that Dr. Mozaffar spoke about, as well as with Carol Gelbard, that is posted right now in our video library. So do go and look at that. So there yet is another benefit to COVID. Essentially, our programs haven't stopped. In fact, they've increased. We because we represent the best interests of the patient, we want to think about them in any possible way, and we listen to our patients. Our certified patient advocates that are now in somewhat 35 countries, as well as doctors and scientists, we have explained to us that, you know, they would like to have conversations on their own. So we facilitate and provide the infrastructure for NDF patient huddles, which happen between patients privately. Nobody else is allowed on that call, and they can talk about any issue that they decide they want to talk about. And then if there is further interest, some of them will come and do presentations in our speaker series for the general population. And we address topics from the latest in scientific research to intimacy issues, to things that are practical items that people have to deal with on the daily basis, such as assistive devices and so on. So we really do think and thank COVID-19 for having expedited what we knew was important and what we did, but to becoming front and center. And of course, one of the main things that's coming out of all of this is taking away the database of patient information from those who have a financial interest in it and putting it in the hands of patients themselves, de-identifying it, and providing that information to science that is 100% confidential and can be trusted because it's for patients, by patients, and monitored by PhDs at Yale and people who understand the protocols necessary. So what we do in all of our programming is always front and center, facing whatever it is that the patient tells us they need, that, as I say, far exceeds the needs that happen in a doctor's office or in a lab. One of my favorite things is the support sessions that we also offer to family members of patients. A patient is often a daughter, a son, a mother, a father, a daughter, and as I say, they have issues that affect them, but so do their family members. So we have support groups for children of patients, family members, and all of these are efforts on our part to address the entire community and see the patient wholly. Of course, we spend a ton of money and effort creating awareness for physicians and neurologists around the United States. We would love to be able to extend that to other countries. And we think that we can launch a campaign using patients to do their own advocacy and talk to doctors about what GNE myopathy is, and we want to create pamphlets, which we also have got some of already, but maybe expand on that and allow you guys to leave a pamphlet at every doctor's office you go to, even if it's for your kids' flu vaccine. It doesn't matter. Leave behind about GNE myopathy just to get the word out. The biggest thing in advocacy is always ensuring that science and biopharmaceutical companies put the patient first. It's not that these people are evil, but it's sometimes when you're removed from the patient, it's easy to forget that we're dealing with human beings. And often myself included, we have intellectual or scientific curiosity, and we want to know what happens. But when it comes to dosing patients or testing on patients and pushing forward an agenda that might lead to a publication or something, but may not be entirely safe for a patient, we are going to get in the way, and we are going to prevent that from happening, because we believe there is the right way to do it and the wrong way to do it. And this is not about money, and this is about making sure that we advocate in its truest sense on behalf of the patients. Of course, raising money for all of this is always a constant struggle, and during COVID-19, I can assure you, has been an absolute nightmare. We have very, very mixed feelings about asking for money, because while we understand that many people are out of work as a result of this, and a lot of businesses have gone belly up, our needs continue and our disease doesn't stop. Basically, what we want to do is to unify the GNEM patients globally. And by unifying the patients, what we're doing is unifying the scientists and unifying the family members and constituents, because there is power in numbers. Those numbers are going to be taken seriously by biopharmaceutical companies, which then further puts us on the map and allows them to work towards treatments. One of the biggest things we do at NDF is scientific research. We're the oldest, longest organization that spent the most money on scientific research to date, in the tune of millions of dollars. What we're doing currently is expediting a treatment for GNE myopathy. The only one that is currently in the works is the MANAC trial, as you guys know, which has been slightly delayed due to COVID-19. We are in discussions with NIH to find out what we can do to help expedite that, if anything. But we believe once it subsides and people are able to go back to the lab, that will be back on track. There is also a talk about this in our video library. Again, I encourage you to go there and look up any topic and listen to the most recent information on all of that. What we believe is gathering up all of the data and centralizing all of the scientific data that we've pooled together as a result of years and years of getting these scientists to collaborate and share information behooves all of us, but ultimately the patient the most. It behooves the scientists from pulling them out of old school ways of doing things in silos for fear of making sure that their publication happens, and the currency that scientists and academics work in is in fact publication. While we understand that that is a thing, we hope that that goes away. And we hope that that goes away because it's too slow and it does not serve the needs of the patient. And I understand that that's controversial, but I believe it's going to be disruptive in that regard. And I can thank COVID-19 for expediting the changes that are happening. But I can also say that NDF's done its part over the years prior to COVID-19 in bringing scientists together and getting them to understand that you will have access to a lot more data if you would only share yours in a centralized database through a consortium and network of scientists, of whom doctors Bhattacharya are a big part. The goal of all of this is to make sure that we have safety and efficacy in anything that we do. We will never test something that we don't feel is safe for a patient, and to de-risk the interest of a biotech by mitigating all of the potential cost of having done all the studies we do and understanding as much about it as we can in order to get them lured and attracted to us enough to understand the regulatory issues in which they specialize and take it all the way to market. Once they have their money in the game and they have some skin in the game, we can assure that that will happen as expediently as possible. So that is our goal. And we have $3 million earmarked for gene therapy to support our continued efforts. While things have been slightly delayed in the lab area, a ton of other conversations have taken place, which actually might be, with which we'll be able to expedite our discussions moving forward, and they're very, very exciting. So stay tuned to that for that. The scientific research that we do really has to ask three questions.
Lale, sorry to interrupt. We need some time for discussion. Could you please wind up? I'm sorry about it, because now we have only 5 minutes left for discussion. Could you wind up your talk, please?
This presentation, we are happy to.
Ma, it's a video. So,
Video, we can stop that.
It's a recording. So you can stop. You can.
Should I stop the video?
Lale, can we stop it now because we are run out of time?
Should I stop the video?
I'm sorry, everybody. I'm having terrible connection issues. It's absolutely fine with me for you to stop the video so that you can have a conversation. My apologies.
Thanks, Lale. Thanks a lot. So we would like to spend a few minutes in taking questions. So,
Yes, completely understood. Yes, I'm sorry. As I said, we've been having terrible trouble all day with our connection.
Yeah. So, Somdat, you can remove it.
Yeah.
So now.
I'm Manisha from Pune. The last year we had gone through a test. I did not receive the results. So when are we expecting?
Hi, are you directing that question to NDF? Yes, all of the samples that we took were sent to PerkinElmer and they were evaluated, of which I think we ended up using 18 of the samples we took from India. All of this information is available for you on our website. A presentation was given about that by Dr. Monko Lek, and if you go to curehivm.org, you will be able to look at that video recording and understand what was done with that and what information. But of course, all of your information was de-identified, so Dr. Lek will not know whether your personal sample was used. Does that make sense?
Yes. Thank you
There's
so
some
much.
questions that people have already asked. For example, Mangesh has asked Dr. Khadilkar that whether de novo mutations are common in recessive disorders. Dr. Khadilkar?
Yeah. I mean, it varies with each disease. But my personal feeling is that with GNE, they are uncommon. And more often than not, we find transmissions. Yeah.
Okay. There's a second.
Any geneticist wants to say something on this?
But, it is coming out to be quite common actually, even for Duchenne muscular dystrophy that.
Yeah. In Duchenne, almost 70% in our collection are de novo. Only 30% are transmitted. Yeah. There it seems to be reverse. Quite right. It's disease specific.
Yeah, disease specific, and it's happening quite often. There's a second question addressed to you also.
I just wanted to Dr. Khadilkar. I think we need to have the testing of also. Then we will to get some data about how common the mutations are. So I think we don't have enough data from parents' mutation profile.
I agree with you. Also, the some of the issues that, I mean, it's everything when you look into it becomes more complex. What is the population statistics of the WAL 727? What does it mean vis-a-vis the disease? I think there are, as you go in the depths of it, there are many questions, but very broadly, you're absolutely right that when we test parents, then we will know more about this. Yeah.
There's a second question addressed to you, Dr. Khadilkar, and people are asking about CoQ10 and other, and this is a question that we receive a lot. Is there muscle supportive therapy that can benefit patients?
Yes. I think it's very good this question has come up, because I also every now and then have to answer this question. See, primarily there are curative therapies and supportive therapies. So for GNE myopathy, we are at the moment not looking at a curative therapy in our clinics. What we are giving is supportive therapy. The supportive therapy is in form of physiotherapy, exercises, understanding the activities, and rehabilitation. That I think is the major part. What you prescribe by way of tablets is only the minor part. So it's primarily physiotherapy and rehabilitation, good square balanced diet, and some supplements. Now, people in whom there are deficiencies like vitamin B12, vitamin D3, so on and so forth, you give them and they feel better. Objectively, they feel better. But the role of coenzyme Q or levocarnitine or carnitine monosulfate and what have you is very little. So we have to appreciate that. That is very little. They are used because you want to use whatever is known. But it's primarily physiotherapy, rehabilitation, square good diet. If there is a specific deficiency, then fill it. And then in addition to give these tablets. So there isn't so much about the dosing and the type that has been used. Its role is limited. Yeah.
Okay, Mainak, you had some question for.
Yes.
You had raised a hand, Mainak.
There are some questions here in the chat box. Can we ask those for Lale? Neetu Singh is asking when the MANLAC trial might start, whether anything can be told about that.
As a matter of fact, yes, that's an issue we've been going back and forth with the NIH on. As you may know, we paid them $150,000 again this year not to abandon that trial and to hire someone full-time to help with that. It's very hard for us to understand. I'm sure the frustrations they're also dealing with, but I know that they're reliant on not just their own department, but also Neuronext, as well as Leadient Biosciences, which is the money behind that. And I'm not sure exactly where the delays are coming in, other than COVID-19 being blamed for that. So we did have them present something. If you go to our website, there is a presentation that they gave via Neuronext on our library, video library, that you can download and watch and get all the details. But we will definitely keep you posted. I know that they haven't been able to finalize the selection of the patients just yet because they can't really fly people in. And that's where we're sort of stuck. So barring any more information, we'll be happy to update you as soon as we know it. But do go look for that video.
Thanks. Okay, there's another question for you, Lale, from Mangesh. If you can quickly give any idea about a timeline, from getting FDA approval to actually getting a treatment out.
FDA approval for MANAC, or are you talking about gene therapy?
No, for gene therapy,
You know, gene therapy is a brand new field. It's something that has not really been tested. There's really only been one approved thing that's been successful so far. We are behind some of our sister organizations, but I can tell you it'll take probably another year to get an IND before it goes into clinical trials. And then of course from there it's phase 1. We may be able to do a phase 1, 2 and phase 3, and then commercialization and regulatory stuff. And that's if everything goes to plan, it will still be several years. So I want to manage everyone's expectations about that. As you may have heard, Audentis recently, which is a company we've been talking to, had a patient who passed away. So that obviously delays everything. And we're grateful that we are not first to market and that we have learned from the mistakes of others.
Thank you, Lale. I think we don't have time now for more questions. There are a few more questions, so maybe we can later request our speakers to answer them at a later time.
On the chat box.
yeah, chat box. So we have to move on to the next session. Thanks a lot to Dr. Khadilkar and to Lale for
Thank
being
you
with
very
us.
much.
Good night, Lale.
Thank you. Thank you
Thank
very much.
Thank you.
And I may have to go to look after some of the hospital matters. So please excuse me for some time. I'll try and come back in the noon.
Thank you.
Yeah, we'll give you some questions which patients
Sure.
have. We'll post them to you.
That's fine by me. I will answer.
Thank you. Thank you so much.
Thank
Take
you,
care,
everyone.
and-
It's very late here, so I'm going to let you go, but I will be happy to
Yeah.
answer questions on the chat box.
Thanks,
Okay.
Lale.
Thank you very much. Goodbye.
Thanks really to come and join us in spite of all the problems that you have.
Yes, no, my pleasure. I'm sorry for all the technical issues.
No. It went perfectly all right.
Take care. Thank you.
Okay. So, Shilpi?
Yeah, so welcome everyone. Hello, my name is Shilpi. Those who don't know me, I'm a law professor and a trustee and a patient of GNE Myopathy myself. And I'm supposed to be taking on from here, and my job is to moderate the sessions, to keep all the speakers to time, and to facilitate the question and answers. So I think some of the speakers already know me. And I apologize in advance if I'm a little bit sort of strict with the time, because we have a very tight timeline. So I'm going to try and keep our speakers to time. So speakers, do maybe keep an eye on your chat box, because I will let you know by chat when your time is going to end. And if I feel that you haven't seen the chat, then I might interrupt you and ask you to wrap up. And I won't be introducing sort of the speakers in detail, because those who've registered, I think, have all received a file with the biographies of all our speakers. So many of the speakers are people you already know. If you do not know the speakers, then please let me know, reach out to me, and I will send you the bio pack of all the speakers. So I won't be introducing each one in the interest of time. So the first panel that we have now is the panel of neurologists, something that I'm also really looking forward to. And I'd like to invite Dr. Nalini to give her talk now. Please, Dr. Nalini. Dr. Nalini, are you there? You're muted, actually, Dr. Nalini.
Media.
Okay, we can see your slides now.
So can you hear me?
Yes.
Oh, yeah, okay. Yeah. Good morning, everybody. And I thank Professor Alok Bhattacharya, Madam Sudha, and Shilpi for inviting me to share my experience on the natural history. Actually, it's a disease progression. So let me just go. First of all, let me thank my colleagues, neurologists, Dr. Seena Saraswati Gautam, who helped me, Dr. Kiran and Pritish, and my national collaborators, Professor Alok and Madam Sudha. And my international collaborators have been Professor Nonaka Nishino and Professor Lockmuller, as you can see here. So the first case of GNE myopathy, which we suspected in 2006, was confirmed at Professor Nonaka's lab, and that was a time of excitement for us. I'm sure that we had tens of cases before this, but we were misdiagnosing those cases or mislabeling them as hereditary motor neuropathies for want of a better diagnosis. So,
Dr. Nalini, could you put this in the
slideshow? I've done it now.
Okay,
I've done it, sorry. Yeah, so this is our multidisciplinary clinic, which has rehabilitation specialists, psychiatrists, social workers, the Ayurveda physician, the occupational therapist, and it is a very successful clinic which is running from 1991, which was initiated by Professor M. Gauri Devi, who currently is in Delhi. And we are very ardently continuing with this clinic, and we have more than 100 cases visiting this clinic once a month. And we have by now registered more than 10,000 cases of inherited neuromuscular disorders in this clinic. So Professor Khadilkar has already spoken to us, and we know that GNE myopathy is a rare autosomal recessive slowly progressive disease with wasting and weakness. And the prevalence varies in several countries, but the highest rates are reported from the Persian Jewish community, the Japan, UK, and Northern Ireland. Among the Roma population in Bulgaria, the incidence is very high, as reported in 1 in 500 births. The global prevalence is estimated at 0.4 to 2.1 per 100,000 population. So typically, the onset is in the late second or third decade, and it begins with a progressive symmetrical or asymmetrical foot drop, followed by lower limb proximal weakness, the upper limb distal weakness, and then the upper limb proximal. The sternocleidomastoids are wasted. The quadriceps is spared even in advanced stages, and this is a very important bedside diagnostic clue for the clinicians. And generally, the ambulation is lost between 10 to 20 years after the onset. So the diagnosis is usually based on pattern of muscle weakness, modest elevation of the CK level, and identification of the mutations in both alleles of the GNE gene. Currently, we do not routinely do muscle biopsy as the clinical phenotype is very typical, and we just follow it up with the genetic testing. So this was of a first paper of 23 histopathologically confirmed cases who had the typical features which Professor Khadilkar was talking about. And the patients generally have a very severe foot drop, weakness and wasting of the medial and the posterior aspect of the thigh muscles and the distal limb muscles. You see that the small muscles are fairly well preserved in this 28-year-old man with a duration of 5 years. Whereas this 45-year-old man has got more profound weakness, and even with this grade 0 weakness and distal upper limb very severe weakness, he was still ambulant with minimal assistance at 45 years. So this was in 2010. So a group of 9 of these patients from this 23, the samples were tested at Professor Nishino's lab, and we confirmed that these patients indeed had GNE myopathy, and that was a second report on the genetically confirmed cases from our group. So basically, the salient demographic features from 2006 onwards, when our first case was diagnosed, we have gathered about 143 confirmed cases, and the mean age onset is around 26 years, and as early as 12 years it could be, and or late as 53 years. And they usually present after a mean duration of 6.2 years, so it's pretty delayed, and as long as 24 years before they present to us. So when did the last follow-up in 2020 June, we had that the mean duration was around 8.6 years, and the longest duration was 38 years of a patient who was still ambulant. So that's a very good news for us in this disease progression, that patients are ambulant. Recently I had a patient of 73-year-old man who walked into my OPD with a classical gait but with a stick, and he also has GNE myopathy, but we have not yet included in this group. So the opposite limb gets affected when there is a unilateral involvement, and the mean period is around 1.7 years. And so it is well known that symmetrical onset is not a classical feature always. The proximal limb muscles could be involved early, and also the upper limb distal muscles come in quite early into the illness. And patients could have a little variable phenotype in about 5 to 8% of the cases. So this was the initial thing that we were doing, was muscle biopsy, and we preferred the tibialis anterior muscle because patients had foot drop, and we have the classical myopathic features, and these are the rimmed vacuoles, which are basically granular deposition, and this is almost quite typical along with the clinical manifestations. Muscle MRI is also very typical. You have the posterior thigh muscles get involved. You see that the quadriceps is very well preserved in early stages or even in the late stages. And in the leg, you have the tibialis anterior group, which gets involved, but even the gastroc is minimally involved, but the patient has preserved power even till late into the illness. And this is a very advanced case where even the gastroc and tibialis anterior is uniformly involved. So we were the first to report on this Beaver's sign, which is a clinical bedside clue to GNE myopathy along with the other clinical features. You have very characteristic muscle involvement of the iliopsoas and the gluteus minimus, which is involved very early. And we did the abdominal muscles to confirm. I have a MRI correlate of this Beaver's sign, and you see that this patient had a 5 years duration, and this is called as T2 haste sequence, where the abdominal supraumbilical region, the abdominal muscles are well preserved, whereas the infraumbilical, it gets involved. That gives rise to this sort of a protruded abdomen or a flabby abdomen. And in this patient, it's even more severely affected. This is at the umbilical and the infraumbilical regions. So this could be an important clue along with the other pattern of muscle involvement in a suspected case of GNE myopathy. So in these slides, let me first thank Dr. Leena, my PhD scholar, and Dr. Mainak, who have helped me a lot in preparing this particular graphs and data entry and analysis for me. So the statewide distribution shows that patients come predominantly from South Indian population, particularly because we are located in South India. And also, as Dr. Khadilkar said, consanguinity is almost in 33% of family marriages in Southern India, which gives rise to more common involvement or presentation of GNE myopathy. In our cohort, we found that there are more men affected. Consanguinity was seen only in about 17%, and family history was seen in 22%. So as mentioned, the initial symptom was predominantly foot drop, followed by lower limb proximal muscle weakness and running difficulty and maybe some muscle cramps. So distal upper limb weakness could also be seen in about 5% of the patients. As you see here, at the first presentation at 6.2 years of duration, the mobility was seen in almost 90% of the patients who were self-ambulant. A small group of 8% required assistance. Wheelchair bound was only about 3% of the patients, and only one patient was bed bound, and the duration was almost 24 years in that patient. So genetic confirmation was done in all the 143 patients, and the reported variants were seen in 52%, while non-reported but novel variants were in 48%. So predominantly we see the compound heterozygous mutations which give rise to GNE myopathy. Homozygous was in just 15%, and heterozygous state was in 14%, possibly unidentified mutation in the other allele. And the common Indian founder mutation was seen, the VAL727 to methionine. And this group, luckily, the Indian patients have a milder phenotype. They have a highest GNEM score and latest age of first wheelchair use. So our patients could be quite happy that with the Indian founder mutation variant, their disease progression is very, very slow, and they have a good functional ability even in advanced stages of the disease. So with the mutation pattern, we found that the kinase-kinase combination was the commonest, whereas the epimerase kinase was the second commonest, and in the smaller group of epimerase was 7%. So we know that the mutations in epimerase domain alone are less commonly identified as disease causing. So the founder variant was seen in about 120 patients, which were pathogenic in 72, lightly pathogenic in 44. The Roma mutation was seen in just about 6 patients, which contributed to 2%, and these were people who had migrated from Rajasthan down south. So at the last follow-up in June 2020, at a mean duration of 8 years, we found that 70% of the patients were still ambulant. Minimal increase in the assistance required in a group of patients. On a wheelchair, from about 4 patients, it increased to 8, and the bed bound was seen only in about 5 patients. So at the end of follow-up, if you see that our first case was diagnosed in 2006, so after 14 years, we said that almost 90% of our patients are still ambulant or with minimal assistance. So for the follow-up and for the functional assessment, we use the IBM functional rating score, which has got 10 domains, involves the bulbar muscles, the fine motor tasks, along with handwriting, which also involves the distal muscles and the proximal muscles, and also activities of daily living, as you can see here. And once the patients are wheelchair bound or bed bound, we can also have assessment, and each of these domains have 4 items, and the score is 4. So the other assessment or scoring that we did was the muscular dystrophy functional rating score, which has got about points of up to 100 and involves the domains of mobility, activities of daily living, arm function, and impairment. So Dr. Nishant did as part of his thesis on this disease progression of GNE myopathy, and we found that at the last follow-up, that is in June 2020, The mean age and duration of illness of this case was administered was 36 years and 8.7 years. So at the end of a long follow-up, the IBM score was 28 and the MDFRS score was 63. So this is a very good score for patients to continue to maintain even after a duration of illness of about 15 to 25 years. So with the disease progression, what were the milestones? So we got a follow-up that was physical follow-up of patients attending our clinic. About 90 out of 143 patients came for follow-up, and the mean duration was around 3 years and as long as 12 years. We did a telephonic follow-up of those patients who could not physically attend our OPD, and that was about 50 patients we got, and then we calculated that the mean duration of illness in theirs was around 8.4 years and as long as 12 years again. So at the last follow-up, we got information from 26 patients who had lost their ambulation and were wheelchair bound. And the time to loss of ambulation in these 26 patients were around 8.2 plus or minus 3.1 years. So it extended from 5 to 25 years. So initially itself, we knew that the patients, two sisters who lost ambulation within 4.5 to 5 years of the onset of illness, had the kinase domain mutations and possibly had given rise to a severe form of the GNE myopathy. So what was the age at wheelchair bound state in these patients? It was around, mean was 31.7 years, and it ranged from 24 to 46 years. So even at 46 years, the patients were ambulant, but several of them had become wheelchair bound. We had only 5 patients as of now from the 143 cohort who have attained the bed bound state, and they attained at a mean duration of illness of 14.2 years, and the range was 10 to 19 years. So, and the age at bedbound state among these was a mean of 38 years and a range of 30 to 43 years. So what did we find from this? That our patients have a very, very slow progression of illness. They're ambulant even after 15 to 20 years after the onset of illness. They may require very minimal assistance to walk. And over the years, we have seen that only 5 patients have become bedbound and 26 patients have become wheelchair bound.
Dr. Nalini,
to conclude, this is the largest series of genetically confirmed GNE myopathy patients from a single center. We found that disease progression showed that majority had a slow progression and were ambulant for more than a decade after onset. The quality of life is maintained at a good level for many years. Findings are similar to other reports from Japan and UK. And obviously, all of our patients and our treating physicians are eagerly waiting for any new drug that we can get for GNE myopathy. So thank you for your patient listening.
Okay, so I just thought I would do a clap. Thank you so much, Dr. Nalini, and also for keeping to perfect timing. That was just absolutely amazing. So we are going to, there are a lot of questions for you, so maybe you can start looking at them in the chat box. Meanwhile, I would like to invite Dr. Vishnu to make his presentation. So Dr. Vishnu, you're up, and then all the questions will be taken together at the end.
So, can you hear me?
Yes, we're just waiting for Dr. Nalini to stop screen sharing.
Okay.
Dr. Nalini?
Yeah, I'm going to put it off.
Okay.
Yeah.
Yes, perfect.
Can you see me?
Yes, we can. Thank you, Dr. Vishnu.
Okay, good morning, everyone. I'm Dr. Vishnu. I'm an assistant professor in neurology at All India Institute of Medical Sciences. I'm an ICG and MD MRC fellow in neuromuscular genomic medicine. And at the outset, I would thank everyone in the world without GNE myopathy for giving us the opportunity to talk on a subject which I've been working for some time, is to set up a neuromuscular clinic at AIIMS, New Delhi. I have nothing to disclose. So, I mean, most of you may have been, I've been told that I should talk in Hindi also in between, but my Hindi is not that great, but I will try to speak in Hindi in between. So there may be grammatical errors, so pardon me. So AIIMS New Delhi is one of the premier institutes in the country. Most of you know it. I mean, I don't want to go into the details. We have a neuroscience center. We have a neurology department, which is one of the earliest super specialty to develop. So so we have a neuromuscular team. By the term neuromuscular team, we means that whoever are engaged in patients, whether it's an acquired or inherited neuromuscular disorders. We have this team of neurology, neurophysiology faculty, the residents, neuropathology and neurophysiotherapy team, the research fellows, the social worker. We have an electrophysiology lab. Recently started an advanced diagnostic facility. We have a collaborative projects with genetics, with IGIB and CCMP. So we have a team, but if you look at the screen, I mean, this is our routine pre-COVID AIIMS neurology clinic. The number ever increasing over the years. I mean, it's been always been difficult to handle our outpatient clinics. And now this is the situation, what happens in a clinic in the COVID era, where the number has, we have been restricting, the OPD was shut down for a long time. Now we're slowly opening it up. So every cloud has a silver lining. So we think that this is an opportunity to catch up on, to create a neuromuscular clinic at this point of time. And in the current status of the neuromuscular clinic, or the neuromuscular patients at our institute now, is that we have a neurology clinic on every day. We have 3 units. We have dedicated clinics only for stroke clinic and the comprehensive MS clinic. But separate files are made for neuromuscular patients called the NMD files. Most of all the faculty who sees their own patients who comes to them. There are no separate day allotted for a neuromuscular clinic as of now, because every day patients are coming to their respective OPDs. So what we have done is we have proposed an AIIMS comprehensive neuromuscular disorders clinic, so like an AIIMS NMD clinic, which was in the pipeline, would have come up by now if not for the COVID. But we hope that post-COVID it will be initiated as early as possible. In this, we're trying to go in a dedicated clinic day on Tuesday, which we're trying to split up in the acquired and inherited in morning and afternoon times, but there may be an overlap. We're trying to get an exclusive phone line, which we have now, for helping with the new and follow-up appointments, and trying to get a neurophysiotherapy appointment on the same day, facility for sampling for genetics after the consent on the same day. And I have been taking feedback from patients and NGOs for how to initiate a neuromuscular clinic. What this presentation I'm trying to do is try and address some of their concerns. Mainly, we have a separate thing for acquired conditions, but I'll focus mainly on the inherited neuromuscular disorders. So I'll put it as a feedback 1 to 10 or something. So one of the feedback, put out the feedback and then see the problem and the solutions. One of the main feedbacks that I received was that limited slots are available, and sometimes if patients have an appointment, have to wait for months, which is true for most of the cases in most of the clinics in AIIMS. We have a long waiting list, probably in neurology also. And the solution to is to start a separate neuromuscular clinic with separate staff and dedicated phone line. I think we are trying to get we already have some project staff who will be looking into it, and we'll have a dedicated phone line, which we have now. So I think that will sort out our appointment system problems. So there's a long walking problems. A lot of patients comes in walking and they're not getting an appointment. AIIMS is a coronary center and a clinical and research center. So we think that walk-in appointments will be restricted to some point of time, because walking comes in only when you are not getting an online appointment. So we'll sort out that online appointment thing, and dedicated phone line and email for an appointment will sort out. The requirement will not require patients to come walking without appointments. So we have a dedicated phone line, which is a number which is for general neurology appointment and for neuromuscular separate. So you can WhatsApp this number from 9:30 to 5 p.m. So we will get a reply within 24 hours. And there's a website, there's a link where you can take an online appointment also. So there's another major feedback I received over the time for the last 6 months is that there's no provision for online consultation. That is probably a pre-COVID issue because COVID has forced us to do a telemedicine thing. That's a good thing that happened during COVID era, and AIIMS now has a very good dedicated telemedicine system. In fact, our department, when the lockdown started on March 25, the very next day we started our telemedicine thing, teleneurology, and it's working very well. So that another thing which was asked was there is no transit facility for NMD patients home to hospital. I think AIIMS, we receive patients from across India, almost every other state. We have patients from every single state in this country. So you have a transit facility. We have a Visram Southern transit facility available, but beyond that, I think it's the teleconsultation is the way forward, which can sort out many of these problems regarding the transit problems. Another thing was that most of the patients wanted most of the things in the ground floor, and an alternative lift facilities available. And in AIIMS, and if you have come to AIIMS, you'll know that all the OPDs and EMG facilities labs are on the first floor. We have the ICUs on the ground floor, ICUs on the first floor. and wards starting from second and third we have the neurosurgery, and fourth and fifth we have the neurology wards. Well, that things is unlikely to change. The wards can't come to the neurology. But what we have done is we have the labs and the OPDs and most of the sample collection system, everything in the ground floor. So don't have to go to one floor above for any of these things. Only if the patients want to get a biopsy done or a daycare facility, then we may have to go to ward. We have dedicated lifts for the patients for that. And they wanted a panel of doctors from every department involving NMD should be available. I think you have seen Dr. Nalini's Neuromuscular clinic, which is a well-established clinic in NIMHANS, where they have a full panel sitting in their OPD. We are trying to get something like that. But everyone in one room is, okay, it's a symbolic question, I understand, but the social distancing issues are there even now. Previously, our OPD used to be packed with patients and doctors. Now things are moving, changing a lot because of the social distancing rules. So we plan to have multidisciplinary meetings once a month, at least online with like a Zoom meeting like this, to have at least the neurologist and geneticists be compulsory will be there, and the physiotherapist and other departments which are involved. If patients are not getting a clarity on those issues, we are trying to get at least once a month an online meeting for that. And we have to ask for a testing facility for all the latest advanced genetic testing. Patients have wanted that this is to be started in NIMHANS and to be free of cost. We have made a point that a single point contact at the first contact from the hospital itself, samples for genetic testing has been done after the consent. And part of this collaborative project with UCL and Newcastle and Cambridge, we have the International Center for Genomics Medicine in Neuromuscular Disorders. So we have a detailed testing protocol. So we initially test for the common conditions, then we go for the genotyping array, then we go for the whole exome sequencing and mitochondrial genome sequencing. If required, we may finally do it in the whole genome sequencing. We are doing a trio samples, which we test the patient's parents also if it's available. So we'll do it all things for all this testing will be done under the research project. So it will be done for free of cost. And most of the genetic testing is done at the CCMP in Hyderabad. So another major query claim was for getting the disability certificate and updating it online. Disability certificate are issued by the medical disability board. I am part of the neurology disability board also. So we have a different guidelines from the government as well. So we'll try to sort out issues, especially the problems is getting an appointment for that. I think neuromuscular telemedicine will help facilitate the process of getting an appointment and getting it issued to the patients. And they wanted, some of the patients wanted a specialized physiotherapy, occupational therapy, and the yoga and pranayama lessons. So we have a dedicated physiotherapy and occupational therapy for the clinic. We have identified someone. And there is a Center for Integrative Medicine and Research, CAMR in AIIMS, which does the yoga and Ayush related research work. We will collaborate with them so that our patients can have access to their facilities also. Another interesting thing which I didn't think of it as initially as a major issue, but many of the patients have complained that the ward boys or who are helping the patients physical examinations to train them how to handle with the patients. So in AIIMS, the helpers in OPD are a floating population. There are contract posts which mean they keep changing most of the time. We are trying to get an exclusive helpers for the clinic. So at least for one person stays for at least for 2-3 years. So and train them. That we'll definitely look into that. And the mental health counseling of NMD patients. Luckily we have the neuropsychiatric clinic, which is the next 1-2 rooms adjacent to my clinic, and that end. So we have on the same day. We should be able to get initially the problem, even though clinics are there nearby, the problem was always getting an appointment. So we will try to sort out that patients get on everything on the same day. And make available new treatments for upcoming treatments for free of cost for patients with NMD. So one of the mandates for our collaborative projects with UCL is to create a trial-ready cohort. So give opportunity for patients to participate in these clinical trials, which patients in our country, we usually don't get an access to those, at least in genetic neuromuscular disorders most of the time. So that this collaborative work will try to get more access to our patients for latest clinical trial. Another one, which was a question which is pure was need to provide online updating of new findings available all over the world to keep patients and parents updated on such findings. So, I mean, there are different ways of doing it, putting up on the website the information, but I believe that social media is a very powerful tool for science communication, and our department has got a very strong Twitter presence. The way once this is formally launched, we'll have a separate Twitter handle for the neuromuscular disorders clinic also. So we we do threads and tutorials on most of the conditions. Recently, for example, I did something on World FSHD Day. We did a full 60 thread tweet tutorial on a thread on facial scapular humeral dystrophy. I'm planning to do something on GNE myopathy also, assimilating all the information that we get after this meeting also. So it helps us, at least it helps general neurologists, it helps the residents, it helps the MBBS students who are following us, the AIIMS neurology and our type handle to get access to awareness of a particular disease and how the features, at least it promotes the awareness, and it also stimulates them to go and look it up. So I think that will help in some of them, and patients also will get, at least we get the latest update from the social media. So on the overall, I think AIIMS, a comprehensive neuromuscular disorders clinic, will be a reality in the post-COVID era. We're just waiting for the clinics to open it in a fully manner. And teleneurology and dedicated phone lines will reduce a lot of accessibility issues, and national and international collaborations will help in getting high quality genetic evaluation accessible to the needy population. So a multidisciplinary approach will help in comprehensive management of patients with inherited neuromuscular disorders as we have planned in our clinic. So and thanks to everyone who has helped, especially to Dr. Padma and Dr. Rohit, who has helped me in taking up this field and trying to establish a clinic here. And thanks to Rob and Caroline of UCL, which they have given some guidance on how to set up a neuromuscular clinic when I was there in UCL for the fellowship program. I think thank you, and I think I didn't overstep the time. Thank you.
Thank you, Dr. Vishnu. You've even bettered us on time. So really, I think you've set the bar high for all the coming speakers ahead of you with finishing so fast. So now I'm going to open up the floor to questions. And I think Tara had raised her hand. So Tara, did you have a question? Did you want to ask a question?
Sorry, I didn't mean to ask a question.
Okay, okay.
I'm just touching my tablet and it's going haywire here. But hello, everyone.
Okay, so I think our first question is from Harmony, who asked, maybe either of you could answer this, whether patients typically have muscle weakness in the abdomen core muscles for GNE. Do you see that?
Did I answer this, Shilpi?
Yes, please, doctor.
Yeah. We've been systematically seeing our patients with GNE myopathy. And in fact, when I reviewed the files, even my first patient seen in 2006, my resident has mentioned that Beaver's sign was positive, which indicates that the lower abdominal muscles have been very weak. So then, but over the last maybe 7 or 8 years, we've been systematically seeing, and this has become a very, very important clinical clue for us, with the pattern of muscle involvement and presence of Beaver's sign gave us a clue that it is GNE myopathy. And it's, at least in our group of patients, or maybe Indian patients, have it very, very common, or almost all of them have it, as far as my experience goes.
Okay, thank you. Harmony, I hope that answers your question. So I think, Dr. Nalini, you answered quite a few of the questions that were there. If anyone had follow-ups on those questions, then they could ask. There was one question to Dr. Vishnu. What about genetic testing in other AIIMS apart from the Delhi one? Can the samples be collected from different places?
Yeah, that we are working on that. Actually, in fact, we have already some collaborative neuromuscular with other AIIMS. For example, in AIIMS Bhubaneswar, AIIMS Bhopal, AIIMS in Rajodhpur, we already have a collaboration working on. So we are waiting for the COVID things to settle down. Once it's settled down, I think we should be able to get the patients may be able to go there and give samples in those AIIMS also. That should be in the pipeline.
And I must add that it's wonderful to see everything that's happening at the new AIIMS Center in Delhi. But for both of you, I, maybe using my privilege as moderator, wanted to quickly ask you, what about sort of pools? So of course, we know that exercising in pools is the best for diseases like GNE, but do either of your centers have pools for physiotherapy?
Lale. at least AIIMS doesn't have any pool for physiotherapy as far as I know. At least in the neurophysiotherapy doesn't have. The main PMR department, I'll have to check whether they have. As far as I know, I don't think they have.
Okay, I have a question, Shilpi.
Yes, you didn't raise your hand though. So,
I can't raise a hand. I'm host.
okay.
So, this is to Nalini. I mean, Nalini, it's a really remarkable body of data that you presented, and I think you have a fairly good grasp on the natural history of the patients. And it is amazing to see some of the data that you presented. For example, loss of ambulation and also the bedridden part of it. You know, if you look at the number of years that takes into getting into it, I don't see any correlation. You know, loss of ambulation takes probably more years compared to some cases on it. So there could be two possibilities. One, the kind of mutation, and it doesn't seem to be a very well correlated something. Or there could be that there are other genetic changes or other alleles that actually influencing the progression of the disease. My only suggestion is that I think this Indian patient natural history should be published. I think we should just go ahead and publish that. I think it's a remarkable, because that's really going to help us doing that. And second thing is that, is there any plan to really look at other changes in the, other genetic markers that actually influencing the gene, influencing the disease?
The phenotype.
Yeah.
Okay. So thank you. So we are in the process. Actually, the mutation and the genotype phenotype correlate and the outcome correlate will soon be done. I need to have my statistician to help me with that. We are just done with the data entry, and this was a quick analysis that we did. And soon we will be out with the correlation studies based on the mutation pattern and the outcome. So that will be done, and of course we are at this manuscript, and soon we will be submitting for publication. And looking at the other mutations, I think the geneticists have to tell us. Obviously, the Nishino's group helped us with the ones which had a single mutation on one allele, and they found large deletions in the other allele, and that is another paper which has been published recently on our patients from Nishino's group, who helped us, unravel the mutation in the second allele. And I think there are several more patients with the mutations, heterozygous state with mutations only in one allele. I think the mutation in the other allele has to be taken up, but I think that somebody who is really interested in genetics should help us with this. And we have almost 20 patients like that who do not have a mutation in the second allele.
Okay. My question was also with respect to other genes other than GNE gene, which can influence the phenotype.
Okay, so there's a question that Dr. Chandak wants to ask.
Can I?
Yes, please.
Okay. Now, great presentations by both Nalini and Vishnu. It actually relates to what Alok finally said, that is there a question of trans heterozygosity, which means that you have mutation in one gene, which is the major gene, and then there are modifier mutations in other genes. I mean, in LGMD, this evidence is so strong, and people have now been looking at this. So, Nalini, do you have any experience of this kind?
So good morning. Nice to hear your voice. So it's like at the moment we have a few of our GNE patients who have undergone whole exome sequencing, and I'm sure that in that whole exome data we should be trying to find if there are any other genes which are relevant, which could be modifier genes and have any impact on the phenotype of the patients. So that will take some time for us. But if you can help us, we'll give you some 50 samples, and maybe you could run whole genome sequencing for us and have some data on this. We have precious samples with us, we would like to share with you. But we will look at the whole exome data, which we have just started working on it, and see if there are anything that we can find in it.
Yeah, I mean, whole exome data itself would be good enough to, start looking at it, because there are many algorithms that people use. So if you have this whole exome data, that also can be shared, and we can look at whole genome sequencing. I don't think is really an idealistic approach for all these cases at this point of time, unless you are in the investigative mode. So we can look at exome data. We can talk about it later, maybe. Just one more question. Can I ask Shilpi?
Very, very briefly, because we
very briefly. Yeah. So I was just going to ask Nalini that you are talking about this natural history, but you must be giving some treatment to these people. Do you think that any of your treatment can modify the natural history?
So we do not advise any specific treatment for any of these patients. Ashwagandha at NIMHANS. All of my patients who visit the clinic get Ayurveda combination of drugs, and the main one is ashwagandha. I'm not sure if any of ashwagandha would help in the alteration of the natural course of the disease, but we do offer that. But we've not done a systematic study on that.
Thank you very much.
Thank you.
So now we have a question from Dr. Katoj, and with that we will have to unfortunately wrap on the questions. So
no, Dr. Chandak asked the same question which I wanted to ask, so answer is there.
Okay, perfect. So unfortunately there are a lot of questions which we will not, because we need to go into a break. So I would really request both the doctors to please address the questions in the chat box if possible, and if you could maybe stay back right now in the break. If anyone has questions, then we can continue. If you don't mind not taking a break, then people, if you have questions, and if the doctors don't mind staying back, then we can continue the discussion. For the other people, we have a break now for 15 minutes till 11 o'clock, when our much awaited gene therapy session will start. So please feel free to use this time to grab some tea or coffee. Unfortunately, we cannot provide it, so we're all carrying our own mugs here. But I would request Dr. Vishnu, Dr. Nalini, if anyone has questions and would like to stay back, please do stay back. Because there are a number of questions also on supplements, because with no treatments, this is the only thing we have. So there are a lot of patients who ask about supplements, and it would also be nice if both of you could give your own advice on what supplements to take.
We will type it, Shilpi.
Okay, perfect. Did anyone have any questions? Please raise your hands if you do. Okay. So it doesn't look like any questions are coming. So next starts at 11.